Hello everyone and welcome to our module on the wrist. Let's start by talking about the wrist bones. The word carpus means wrist, and there are 8 carpal or wrist bones. Their names are shown on the slide here with a letter that corresponds to the X-ray image on the right side of the screen. 4 of the bones are considered the proximal carpal bones. Those are A, B, C, and D. This group includes the scaphoid bone, which is the most commonly injured carpal bone. The other 4 bones are called the distal carpal bones. So let's talk about the scaphoid bone. This is the most commonly fractured carpal bone, and you can palpate your scaphoid bone in your anatomic snuff box, which is a depression on the back of your hand circled here in this picture on the top right. Snuff is a form of tobacco, and some people inhale it by placing a little bit of it in the anatomic snuff box. This bone is classically injured in what's known as a fouche injury. A fouche injury is a fall on an outstretched hand, and that can lead to a scaphoid bone fracture. An example of an X-ray of a scaphoid fracture shown at the bottom right side of the screen here. You can see that there's a crack through the middle of the scaphoid bone, which sits right on top of the radius. And there are 2 classic complications of scaphoid fractures you should know for your boards, and those are avascular necrosis and non-union. The scaphoid bone sits right on top of the radius, and if you know that, it's an easy way to remember that the radial artery is the blood supply to the scaphoid bone. It gives off branches called palmar and dorsal branches that deliver blood to the scaphoid. But the way this works is that the artery delivers blood to the distal portion of the scaphoid, and then blood works its way back proximally. What this means is if you have a fracture, especially a fracture in the middle of the bone, then this proximal portion is going to lose its blood supply. That's because the proximal portion relies on retrograde flow. So for this reason, avascular necrosis is a classic complication of a scaphoid fracture. This is loss of blood supply to the bone. This is especially common in waist fractures. So looking on the screen here, this is the waist of the scaphoid bone, and a fracture here can cut off blood supply to the proximal bone and lead to avascular necrosis. And then because of avascular necrosis, sometimes scaphoid bones have what's known as non-union. This is failure of the bone to heal, and this also happens because some of the bone has lost its blood supply. The scaphoid is the most important wrist bone for you to know about for your boards, but if you want to know about one other, know about the lunate bone. So the lunate bone is B in this image on the screen here, and it sits right on top of the radius, and a lunate bone dislocation can occur from trauma or a fall. The reason for this is because the lunate is attached to the radius, and you can remember that easily if you know that it sits on top of the radius. So sometimes in a fall, the wrist bones will be forced backwards, meaning away from the palm, but the lunate, because it's attached to the radius, will be held forwards and displaced toward the palm. This is called a lunate dislocation. And the patient will present with a wrist that is painful and swollen, and on X-ray, the lunate will be dislocated towards the palm. This is an uncommon wrist injury, but the main reason they may ask you about it on your boards is because the lunate sits right on top of the carpal tunnel. So when it is displaced anteriorly, it can compress the carpal tunnel, and that can lead to median nerve dysfunction. So that's a nice segue into carpal tunnel syndrome, which we'll discuss next. And let's begin by defining the carpal tunnel. So I told you that the word carpal refers to the wrist bone. So the carpal tunnel is a tunnel near the wrist bone. So if you look at this drawing on the screen, these are the wrist bones on the back of the hand. This is the palm of the hand, and just under the skin of the palm of the hand is a structure called the flexor retinaculum. It's also called the transverse carpal ligament. And between this ligament and the bones, you find the carpal tunnel, and that is where the median nerve runs. And therefore, if the carpal tunnel becomes compressed for any reason, the median nerve can become abnormal, and that can lead to median nerve dysfunction. So carpal tunnel syndrome is entrapment of the median nerve in the carpal tunnel, and patients present with symptoms of median nerve dysfunction. In the video on the hand, I talk about median nerve lesions in detail, but I'll briefly review the findings of a medial nerve lesion here, the type of findings you can see in carpal tunnel syndrome. So the median nerve provides motor innervation to the thumb side of the hand. So in a median nerve lesion, you can see motor loss to the thumb side. This can include problems with thumb movement. That's because the thenar muscles are innervated by the median nerve and they move the thumb. This can also include problems on flexion and extension of the lateral fingers. Those are the 2 fingers closest to the thumb, and that's because the lumbrical muscles are also innervated by the median nerve for the lateral fingers. In terms of sensory symptoms, the median nerve provides sensory innervation to the thenar eminence and the lateral 3.5 fingers. If you look at this picture at the bottom of the screen here, this is the palm side of the hand. Everything in brown here is sensory innervated by the median nerve. Now, a special point on carpal tunnel syndrome. There is a small branch of the median nerve that comes off before the carpal tunnel and does not run through the carpal tunnel, and it provides sensory innervation over the thenar eminence right here. So for this reason, in the carpal tunnel syndrome, you usually see sensory loss on the palmar side of the lateral fingers, but not over the thenar eminence. That's a special thing that has to do with carpal tunnel syndrome and median nerve problems that result from that syndrome. So when the median nerve is compressed in the carpal tunnel, that leads to the carpal tunnel syndrome. This usually begins with sensory symptoms. If it's untreated for a long period of time, it can progress to motor symptoms, but in modern practice, motor symptoms are very rare because people usually come to medical attention before this happens. The classic hallmark is pain or paresthesia, usually described by the patient as numbness or tingling in the distribution of the median nerve. So remember, this is going to involve the lateral fingers near the thumb, but it's not going to involve the thenar eminence. Those are the classic findings in the carpal tunnel syndrome. So who is at risk for carpal tunnel syndrome? Well, for years it was thought that if you have a job where you repetitively use your hands or wrists, this could cause the carpal tunnel syndrome. So for example, especially people who sit at a desk and type all day, it was thought that that activity led to the carpal tunnel syndrome. This is controversial, however, because a lot of studies have not borne this out. Other risk factors are shown in this slide. Obese patients are more likely to get the carpal tunnel syndrome. Pregnant women may develop this syndrome. It's thought to be because of edema around the carpal tunnel. And then other risk factors include some other disorders like diabetes, rheumatoid arthritis, and hypothyroidism. There are a couple of rare disorders that are strongly associated with carpal tunnel syndrome, and these are the things that are very high yield for you to know for your boards. The first one is acromegaly. Acromegaly is caused by growth hormone excess in an adult. This is often caused by a pituitary adenoma, and I talk about acromegaly in more detail in the endocrine video on the pituitary gland. But patients who develop a growth hormone excess in acromegaly will have their jaw grow and they will develop coarse facial features. But in addition, their hands and feet will grow. This is a picture of a patient with acromegaly on the bottom of the screen here. This is the patient with acromegaly. This is a normal hand on the left. You can see how the hand is much bigger. That's caused by growth hormone excess. A classic sign of acromegaly is a patient who says their glove or shoe size has gone up in the last year or so. They may complain that their rings no longer fit, and then up to a third of patients with acromegaly develop carpal tunnel syndrome. It's high yield to remember that, and it's easy to understand their hands are getting bigger, and this can lead to compression of the median nerve in the carpal tunnel. Another high yield cause of carpal tunnel syndrome you should know about is dialysis-related amyloidosis. I talk about amyloidosis in a video in the hematology section. There are a number of forms of amyloidosis, but in a dialysis-related form, amyloid deposits form from beta-2 microglobulin, which is a component of MHC class 1 as shown on the screen here. This is a complication of renal failure. That's why it's called the dialysis-related form of amyloidosis. It happens to people who are on dialysis, and the reason it occurs is because dialysis does not effectively remove beta-2 microglobulin, so it deposits in bones, joints, and tendons and causes amyloidosis. This can cause shoulder pain because it likes to deposit in the joints of the shoulder. It also often causes carpal tunnel syndrome. So many patients who are on dialysis for end-stage renal disease develop carpal tunnel syndrome, and this is often the mechanism. It's because of dialysis-related amyloidosis. There are a couple of classic maneuvers that you can do at the bedside for carpal tunnel syndrome. One is called eliciting Tinel's sign. To elicit this sign, you ask the patient to extend their wrist, and then the clinician percusses or taps lightly over the thumb side of the wrist. If the patient notes tingling in the distribution of the median nerve, this is a positive test for carpal tunnel syndrome. The other maneuver is called the Phelan maneuver. In this maneuver, the patient is asked to flex their wrist and hold it for a minute. If they develop tingling in the distribution of the median nerve, that is a positive test. Now let's talk about Guyon's canal, which is also called the ulnar canal. This is the ulnar nerve equivalent to the carpal tunnel for the median nerve. Guyon's canal is how the ulnar nerve gets into the hand, and it can become compressed and lead to ulnar nerve dysfunction. Guyon's canal is found above the transverse carpal ligament, and the roof is formed by the palmar fascia. And the fact that it's above this ligament is very high yield for you to know. This is an important distinction between Guyon's canal and the carpal tunnel. Let's look at this drawing on the screen here. These are the carpal bones here, and this is the median nerve found in the carpal tunnel, which is below the transverse ligament shown here. The ulnar nerve is found above the transverse ligament. That's Guyon's canal. It's between the transverse ligament and fascia of the palm up here. And this is where the ulnar nerve passes into the wrist, and if this canal becomes narrowed or compressed, that can lead to ulnar nerve lesions. In the video on the hand, I discussed the clinical findings of an ulnar nerve lesion in detail, but I will briefly review them here. First of all, in terms of motor function, you can lose abduction and adduction of the fingers because this is done by the interosseous muscles, which are innervated by the ulnar nerve. You can also have motor loss to the little finger side of the hand, including the little and ring fingers. This is because the hypothenar muscles and the median two lumbricals are innervated by the ulnar nerve. And then finally, you can also see sensory loss on the little finger side of the hand. If we look at this picture on the screen here, Everything shown in blue on the palm side here and the dorsal side here is innervated by the ulnar nerve, so you can have sensory symptoms in those regions. Guyon's canal syndrome is the clinical finding of an ulnar neuropathy at the wrist caused by compression of the ulnar nerve in Guyon's canal. It's often seen in people who overuse the wrist. In many cases have been reported among bicyclists. This is thought to result from direct pressure on the wrist on Guyon's canal from the handlebars. I'll finish this video by describing two pediatric fractures you should be familiar with. So children often fracture their bones, especially the bones near the wrist and in the forearm, from trauma, but children's bones are softer than adult bones, so children often have incomplete fractures. In other words, the bone doesn't completely snap in two. And there are two classic pediatric incomplete fractures you should be familiar with for your boards. The first one is called a green stick fracture. This is basically a bent bone. There's a fracture, but it does not extend through the width of the bone. It often occurs in the distal radius right near the wrist from trauma, and this happens when there is a bending force from the side that's applied to the bone. It often happens as part of a fouche injury, a fall on an outstretched hand. Here's an example of a green stick fracture shown on the screen here. You can see that the radius bone is bent and that this fracture does not completely extend through the bone, but part of the bone is still attached on the side, and that's what causes it to have this bent formation. That's called a green stick fracture, a classic incomplete fracture seen in children. The other incomplete fracture is called a torus fracture, or sometimes it's called a buccal fracture. This happens from an axial force trauma, meaning a force applied into the bone. So for example, if you look at this drawing of a bone on the screen here, if we applied a force this direction right into the bone, that's what causes a torus fracture. It usually occurs in the distal metaphysis, so some brief terminology of long bones here. The shaft is called the diaphysis, that's the long part here. The epiphysis is the rounded end, and the metaphysis is the widening right before the rounded end. And it's at this metaphysis that the torus fracture often occurs. That's because this is the most porous portion of the bone. Shown on the screen is an example of a torus fracture of the radius bone. These fractures can be subtle, they're not always obvious, but at this portion of the bone right here, you can see it's whiter than the rest of the bone. That's because a force has been applied in this direction and the bone has basically piled up on top of itself, causing this torus fracture, the other classic form of an incomplete fracture seen in the pediatric population. And that concludes our video on the wrist.